Hello everyone, this is Dr. Mushfiq Tarafdar once again. In this week's lecture, we'll learn about basics of person-to-person infection transmission models. As you know from the previous lecture, droplet transmission, which is the main route of transmission for SARS-CoV-2, fall under person-to-person transmission since close proximity is needed for the spread of infection. Similar to the last lecture, I'll be using SARS-CoV-2 as an example wherever applicable and appropriate. Our standard copyright notice, all materials found on GCSOM's course and project sites may be subject to copyright protection and may be restricted from further dissemination, retention, or copying. Disclosure, I have no current financial relationship with a commercial entity relevant to this educational material. At the end of this lecture podcast, you'll be able to define EpiCarve and discuss its characteristics. You'll be able to discuss the basic concepts in mathematical modeling of infectious diseases. You'll be able to describe SIR compartmental model and define the parameters used in the model. You'll be able to describe patterns of transmission and types of models, and you'll be able to discuss the role of mathematical modeling in prediction and control of transmission of infection. First, let's learn a little bit about epidemic curves or EpiCarves. EpiCarve is a graph, a histogram to be precise, of the cases according to the time of onset of illness. The overall shape of the EpiCarve can reveal the pattern of spread, whether it's person-to-person spread or a common source spread or a point source spread. It can also tell us about the magnitude of the epidemic. It also shows the rise and fall of cases over time or the course of an epidemic. And sometimes it can tell us about the incubation period of the infectious agent. Although EpiCarves are commonly used to show cases, it can be used to show hospitalization and deaths. When we have person-to-person spread in an epidemic, which is also known as a propagated epidemic or a propagated outbreak, the transmission of infection may continue for a considerably long period of time, and we may see multiple waves in the EpiCarve. If the epidemic is confined within a relatively small geographic area or a small population, then we may see progressively taller peaks in the EpiCarve, often one incubation period apart. On this slide, we have an EpiCarve showing COVID cases from Pennsylvania by onset date, showing cases from late February all the way through early part of October. On this slide, we have an EpiCarve showing COVID-19 associated deaths reported from New York City from mid-March through late April. And this EpiCarve is showing COVID-19 deaths in the United States reported to CDC from mid-March to mid-October. So what is transmission dynamic model or mathematical model for infectious disease transmission? Transmission from one host to another is fundamental to the survival strategy of most infectious agents. And this transmission of infection from one host to another follows a set of underlying principles, which is captured in a wide variety of mathematical models. Transmission dynamic model is a collection of assumptions that are combined together to give a quantitative framework describing the numerical changes expected if the assumptions hold. It's a tool that allows us to understand this complex system of interactions between infectious disease agents and hosts. It tries to present that complex system in a simplified manner. The quality of the model will depend on the accuracy of the assumptions that are used to build that quantitative framework. Mathematical models in infectious disease epidemiology have two broad but distinct roles: prediction and understanding. And they assist us in answering questions like how quickly will the epidemic spread, how many individuals will be affected, what interventions will reduce transmission and by how much, what strategies would be effective um, and also cost effective, and how resources should be allocated. To summarize, mathematical models of disease transmission may be developed and used for three reasons: to better understand the effects of interventions in disease control processes, to develop predictive models of disease transmission within populations having set characteristics, and to gain insights into the epidemiology of the disease in those populations, and to estimate transmission-related parameters. There are three key factors in transmission modeling: contact, which is influenced by host behavior and demography; a route of transmission for COVID-19, this is droplet transmission or person-to-person transmission; and life history of infection in hosts. The nature and frequency of contacts is heavily determined by social structure of the population. The two important things that we need to know and understand related to host behavior are rate of mixing and the type of mixing. Population density also significantly influences transmission of infection. Age structure also plays a role in mixing and transmission of infection in a population. Mixing is considered homogeneous if everybody has an equal chance of contacting everybody else and everybody has the same average experience. Mixing is considered heterogeneous if either a person is more likely to contact others with certain characteristics, for example, age or occupation, or if some individuals have higher contact rates than others. Heterogeneity in contact patterns and contact rates is particularly important as some people are both more likely to be infected and more likely to infect. This group is termed a core group. When we're modeling transmission of an infectious agent, it is necessary for us to know the stages and the time periods in the natural history of that infection. We learned about these stages and time periods in the previous lecture, namely the latent period, infectious period, incubation and symptomatic period, and we also learned about the main characteristics of asymptomatic infection. In mathematical modeling, to understand the transmission dynamics of the infection, we divide the population into multiple compartments according to the state of the host. In the most basic or the simplest model, we have three compartments. One compartment for susceptibles, one compartment for infected and infectious individuals, and a third compartment for recovered, immune, and deceased individuals. This compartmental model is known as the SIR model, sometimes called XYZ model. Individuals move between compartments according to certain rates. So as I just mentioned, the simplest model of person-to-person transmission has three compartments: susceptible compartment, infected and infectious compartment, and recovered or removed compartment. Although here I've labeled the middle compartment as infected, but this is the compartment where we have individuals who are infected as well as infectious. Now, SIR model is a variant of the SIR model where we have an additional compartment, the exposed compartment, which includes individuals who are in their latent period. Let's use this flow diagram of SIR model to learn about and understand a few additional compartments that are important in the mathematical modeling of a disease. So individuals who are in the recovered compartment, if the infection confers immunity, then they will move to the immune compartment. If immunity is lifelong, then those individuals will stay in that compartment for the rest of their lives. For COVID-19, which has been with us for almost a year now, at this point we can say that a natural infection with COVID-19 confers immunity for about a year, but as we move forward, we'll learn more about the length of the immunity conferred by natural COVID-19 infection. Now, if immunity is lost at a certain point, then those individuals in the immune compartment will move from that compartment back to the susceptible compartment. Now, if for a certain infection, if there's no immunity conferred, then as soon as those individuals recover, they go back to the susceptible compartment. When we'll have a vaccine for COVID-19, most of those vaccinated individuals, if not all, will move directly from the susceptible compartment to the immune compartment. Now, the symptomatic stage or the disease stage of an infection may influence the probability of transmission of infection to susceptible and exposed individuals. However, that diseased or symptomatic stage is more important when we're thinking about hospitalization and death. Now, in a dynamic or open population, there'll be travel, which will bring new susceptible individuals and infectious individuals to our population. So new members will be added to the susceptible compartment and to the infected and infectious compartment. Finally, if the infection becomes endemic, then through new births, members will be added to the susceptible compartment. As I mentioned previously, individuals move from one compartment to another at certain rates. The rate at which individuals move from the susceptible compartment to the infected and infectious compartment is called the force of infection. It is denoted by lambda. Lambda is the product of Cp and 1 over n, where C is the contact rate per individual per unit time. P is the probability of transmission when a contact is made between an infectious individual and a susceptible host. And 1 over n is the proportion of infected individuals in a population. Now, as I mentioned previously, contact rate depends on the social structure in a population, the population density, as well as host behavior that determines the frequency and the type of mixing, often called who mixes with whom metrics. One paper that used data from China reported P, or probability of transmission value, of 0.063 for symptomatic COVID patients and a probability of transmission value of 0.041 for asymptomatic infected individuals. And if we add the exposed compartment here, then force of infection is the rate at which individuals move from the susceptible compartment to the exposed compartment. The rate at which individuals move from the exposed compartment to the infected and infectious compartment is the inverse of the latent period, or 1 over latent period. The rate at which individuals move from infected and infectious compartment to the recovered removed compartment is called the rate of recovery, and it is denoted by gamma. Gamma is the inverse of the period of infectiousness. For COVID-19, the period of infectiousness ranges from 4 days to 14 days. Now, to figure out the rate at which individuals move from the infected and infectious compartment to the disease or symptomatic compartment, we'll need to know the proportion of symptomatic cases out of all infected individuals, and also when individuals become symptomatic following COVID-19 infection, which is the incubation period. So for COVID-19, the incubation period is between 4 and 6 days. And according to CDC's current best estimate, about 40% of the infected individuals are asymptomatic, which tells us that about 60% of the infected individuals are symptomatic. Now, from that disease or symptomatic compartment, individuals may recover at the rate of gamma, or some individuals may die and move to that diseased compartment, and some will be hospitalized and move to that hospitalized compartment. Now, the rate at which diseased individuals move from that disease symptomatic compartment to the hospitalized compartment will depend on the percent of the patients requiring hospitalization, and also the time between the symptom onset and hospitalization. And according to CDC, about 19% of the COVID-19 patients require hospitalization. And also, according to CDC's current best estimate, the time between symptom onset and hospitalization is 4 to 6 days. Finally, to figure out the rate at which individuals move to the deceased compartment, we need to know the case fatality rate. For COVID-19, we know that ranges between 2.3 to 2.8% in the United States. And we also need to know the time between the onset of symptom to death, which again, according to CDC's best estimate, is somewhere between 13 and 17 days. So how all that information about SIR compartmental model and the rates at which individuals move from one compartment to another help us figure out the effect of different prevention and control measures on the transmission of infection. So in force of infection, C times P is called the effective contact rate. Now, thinking about COVID-19 infection, self-isolation, social distancing, hand hygiene, all those can have an impact on that effective contact rate and can reduce the effective contact rate, which in turn will reduce the force of infection. Now, through testing, we can identify infected individuals, both symptomatic and asymptomatic. And then if we isolate them, then we're effectively removing those infected individuals from the calculation of lambda, which in turn will reduce the force of infection. And when we'll have a vaccine, that will effectively remove individuals from the susceptible compartment. So there will be fewer susceptibles in the population to begin with. Keep in mind that when we have fewer infected individuals, that means there'll be fewer symptomatic or disease individuals and fewer hospitalizations. Now, thinking about rate of recovery, if we have an effective treatment that reduces the duration of infectiousness, that means that we'll have a smaller gamma and a faster rate of recovery. So individuals will move from infected infectious compartment to the recovered compartment at a higher rate. One good thing about appearance of symptoms is that it makes us aware of the presence of the disease. And if that is followed by isolation, then that will reduce the force of infection. Hospitalization has the same effect on the force of infection. And finally, if we have an effective treatment, then it can reduce the duration of the symptomatic phase, and it can also reduce the number of hospitalizations and the number of deaths. So we just reviewed a simple deterministic compartmental model. Deterministic models assume that the course and the size of an epidemic is always determined by a fixed set of parameter values and there's no variation. So if the same epidemic happens again, we will have the exactly same outcome. It ignores the chance nature of transmission. A deterministic model is a good approximation of the transmission dynamics in a relatively large population with high levels of disease incidence. On the other hand, stochastic or probabilistic models take into account the chance nature of transmission. And because of that, in principle, stochastic models are more realistic than deterministic models, especially early during an epidemic. A stochastic model gives us a good approximation of the transmission dynamics when the population is relatively small or when the disease is rare. However, stochastic models are more mathematically complex. A series of computer simulations are done to figure out all the possible outcomes in an epidemic. By definition, all models are wrong in the sense that even the most complex models will make some simplifying assumptions. It is therefore difficult to express definitely which model is right, though naturally we're interested in developing models that capture the essential features of a complex system. So ultimately we're faced with a rather subjective measure of the usefulness of a mathematical model.